Yes, I have a spinal cord injury, so I'm limited in some of my mobility, and therefore Courtney's going to be a big help for me as we go through the slides. I'm a vascular neurologist, so there's going to be a bias a little bit in the presentation related to stroke scales. But in fact, when I was on NIH study section, I quickly realized that the vascular community was a little further ahead than some of our colleagues in neurology in the development and implementation of scales. But scales are going to be very important in any clinical research study. Let's go on to the next slide. I do not have any conflicts of interest. We'll go on. So when we pick outcome measures, this is an important component of a clinical trial. These are going to be looking at your specific aims. There are both clinical and then surrogate outcome measures. And these will be disease specific. For example, stroke scale measurements probably will not work in a patient with multiple sclerosis. I'm going to emphasize clinical research in stroke, as I mentioned, because of my past experience. Next slide. Now, there are terms or qualities of outcomes that can be used in any clinical study, research study in neurology. The terms of impairment or the degree of neurological abnormalities found on examination, handicap, how the neurological impairments limit the patient's activities, and disability or participation restriction is how the patient's role in society is impacted. So for somebody like me, I have neurologic impairments in my arms and legs. I do have obviously secondary activity limitations, and there are participation restrictions that are secondary. So all those apply to somebody like me. Another outcome measure is mortality. And depending on the clinical trial, this may or may not be a good outcome measure. It may be a good outcome measure for evaluating patients with subarachnoid hemorrhage or craniocerebral trauma, but generally it's not a good outcome measure for most other neurologic clinical research studies. Quality of life, which is more subjective, is an important ancillary outcome measure, as are healthcare costs, recurrent events, neurologic worsening, depending on the type of the study, that will be maybe an important outcome measure. And then, of course, adverse events, including those that are anticipated or not expected. Next slide. Now, there can be surrogate markers for outcomes in patients with neurologic disease. These include abnormalities in brain imaging, functional imaging, vascular or other imaging, biomarkers of a wide variety of types, physiological studies, and these are all extremely useful and are going to continue to be very important in evaluation of patients with a broad spectrum of neurologic diseases. Next slide. However, clinical outcomes remain the most important. When I was on the FDA advisory committee, we were told loud and clear that if the patient may have had improvement on an ancillary study, whether it's imaging or biochemical, it was not as important as the clinical outcomes. In other words, if the patient is not better or etc., the imaging study results will not substitute for the clinical findings. Next slide. Now, when we design, we want to think about what kind of trial we're doing. We can do a prevention study that prevents neurological worsening or recurrent events. These would be obviously a study that would be extremely important in multiple sclerosis. There are acute treatment studies that would be more commonly given, something like stroke, where you're limiting the primary injury or preventing or treating complications such as brain edema or hydrocephalus. You can do recovery or rehabilitation studies. which are going to look at ways to limit the neurological sequelae of the neurological illness, or that may help maximize recovery from the event. Next slide. Now, when you get to, for example, ischemic stroke, which is where I've done most of my research, we have to recognize there is a broad spectrum of vascular diseases due to a wide variety of causes with a lot of comorbid problems and multiple other therapies that are being given. So we need to remember that the intervention, whether it's TPA or something else, has to be put into the realm of how the patient is being treated. Next slide. Now, clinical, as I've said, the clinical rating instruments are now being used in practice because we have found that both the information is important for both researchers and clinicians. Some of the indications are, for example, the NIH stroke scale being used in emergency departments and national guidelines. They can be used to determine changes in neurological status. The Kurtzke scale for multiple sclerosis would be an example. It will influence acute and long-term management decisions. And of course, for a clinical study looking at ways to improve outcome, you want to see the responses to the therapy and how it impacts outcomes. Next slide. Now, what you want in a useful clinical rating instrument, it has to be credible. What do I mean by that? That it makes sense to doctors, patients, regulators, reviewers for grants. It has to be understandable. A knowledgeable person in neurology should have an image of the patient status when given the score. For example, if you see a patient that comes in with a Glasgow Coma score of 5, you have a patient who is unbelievably sick, and you know the prognosis is not going to be good. If a patient comes in with an NIH stroke scale score of 5, that's generally going to be a mild stroke, and the patient has a high degree of a favorable outcome. So these will be important for everybody involved, the patient's family, the community, the physicians, etc., and most importantly, the researcher. Next slide. Now, when we use a clinical rating instrument, we want to know what the purpose of the scale is going to be and what information will be gained from its use. Therefore, it has to be relevant to the patients. Most scales are based on items assessed by history or examination based on the patient's performance. At the end, you want to know how this scale will interact with other rating instruments or surrogate markers. And you need a clear plan for testing and validating the instrument. Next slide. Now, what are the attributes of a useful clinical rating instrument? It has to be easy to use. It should not be time-consuming or burdensome for either the patient or the assessor. One of the scales I'm going to mention later on is the Fugl-Myer score. We tested it here at Iowa. It took 45 minutes for the coordinator to administer. By the end of the 45 minutes, neither the coordinator nor the patient were very willing to do it again. We need to have clear and straightforward definitions and instructions on how to do it. The scale has to be reliable and reproducible. It means that if 2 raters assess the patient at the same time, hopefully their score will be relatively close. Similarly, if an examiner goes back and examines the patient again, he or she should be able to come up with basically the same score. Some rating instruments are very difficult, and that requires educational and even certification programs. These steps are especially crucial for clinical research studies. Next slide. Now, for clinical research studies, you need to assure the reviewers of your grant, the FDA, NIH, the medical community, that the scale has been administered correctly, and the scoring or whatever it is accurate. In other words, this is the basic credibility of your research project. Next slide. Now, therefore, you should use, whenever possible, well-validated scales. This becomes crucial because it will allow the readers of your research, other clinicians in your area of research, to compare your results with another research study. Nowadays, because of this is so important, funding agencies such as the NIH and regulators such as the FDA are requiring that you use well-validated scales. In addition, you have to come up with a way to educate and certify the people that are doing the rating and scoring. One of the ways that is now becoming more popular is central adjudication, where the examiner does a videotape of the exam, and that is forwarded to a central blinded group that will assess the scores and determine the final results. This may not be done at every clinic visit, but it may very well be done at the final visit at the end of the study. It also is not very practical, given the constraints of enrolling patients to do this at baseline. But even there, this is an option depending on the study. Next slide. Now, many investigators want to do a new scale. We're going to come up with the new wonder scale. Now, the problem is that takes time. It delays the primary goal of the project. And I would encourage the third-party reviewers, the NIH, the FDA, are not going to be very excited about it. So I would encourage you to adopt current available scales for your research project whenever possible. Now, I realize that there are some scales that may not directly apply. One of the people that I've been advising is trying to find a scale that will work for a relatively rare disease. And it has been a big issue. But wherever possible, don't spend time creating a new scale, because it is going to be a dead end. Next slide. Now, there are basically two types of scales. There is a numerical score with a score of 10, for example, based on scoring of individual components of the assessment. Others will have a single score scale based on an aggregate of all information. So everything is put together and you get a score. For example, the Asia score for spinal cord injury goes from A, B, C, D, E. And what is crazy is A, which is the worst outcome, and E is the best. And as a patient who's had a spinal cord injury, I always wonder why it's backwards, but that's the way it is. Next slide. So numerical scores have several items that are assessed and scored individually. Each of these scores are then added up to give a total score. Now, for example, with the NIH stroke scale, you can get 10 points by many different ways. Depending on the score of the scale, a high score can be good or bad. For example, with the NIH stroke scale, you want a low score, like golf. You want to be in the master tournament rather than at the local one. Next slide. So let's look at the NIH stroke scale. Now, it's used for the baseline severity of stroke, so we know how bad the patient is. This has become an entry criterion for multiple studies. The baseline NIH stroke scale affects prognosis. It's the single biggest predictor of how a patient's going to do. It can give you, therefore, affect decisions for treatment. It may be used to monitor improvement or worsening after interventions. And then it can be used as an outcome measure. So the NIH stroke scale, for example, is being used in all those settings. Next slide. So when we talk about the NIH stroke scale, which we developed back a long time ago, you can see at the bottom there, 1989, it was published. There are 15 items. Each item is scored independently and given a baseline severity of neurologic impairments. The range of the NIH stroke scale is 0 for normal to 42, which is the highest possible score. Actually, you can't get 42 on the NIH stroke scale because some of the other things will knock out other parts of scoring. Obviously, the higher the score, the more severe the stroke. Next slide. We did initial validation of this and found a reasonable degree of inter-rater agreement and retest reliability. We use the outcomes based on the size of the infarction on CT and clinical outcomes at 3 months. It was tested by other clinical researchers and has now become internationally the paramount scale for stroke research. Next slide. I put this in from some of our research to show how the NIH stroke scale worked. If you look at the bottom, you can see the baseline score of when patients came in. And you can see that as the patients had more severe strokes, the prognosis went much higher, with the red bar showing the increase in mortality and the white bar showing the excellent outcomes. You can see how big an impact the score had in predicting. I don't know if any of you on the group are from Colorado, but I like to say between 5 and 15, you're on the double black diamond slopes at Arapahoe Basin as you go up there very, very rapidly. Next slide. Now, what we also did is we did a certification process where all the investigators and the coordinators had to go through testing, remediation, and reliability assessment. We found that generally everything worked well except 2 components of the NIH stroke scale: facial weakness and limb ataxia. The facial weakness and the limb ataxia were put in primarily to assess vascular events that were affecting the posterior circulation in the brainstem and or cerebellum. But those have been difficult. Next slide. Now, so what do we have with the NIH stroke scale? It is now a validated measure for stroke severity. It can be done in person or it can be done over the internet. It does predict outcomes and for planning both acute and long-term care. It has now been adapted from English into other languages and cultures, and we do have educational and certification programs. I do not know if any of the participants are planning to do a research study in cerebral vascular disease or stroke, but you will be strongly advised to use the NIH stroke scale as part of your clinical assessment tools. Next slide. Now, there are some disadvantages of the NIH stroke scale. When we brought it up, we found out that there is a bias towards the dominant hemisphere. So that if you look at CT volume as a control, as an outcome measure, strokes in the right hemisphere have lower scores than those in the left. And this has the issues related to a couple of questions in the cognitive assessment, which are orientation and commands, which are obviously strongly linked to language. We do have raters that can interpret things differently. Where we run into trouble is, as I mentioned earlier, was the facial weakness and ataxia, and surprisingly, the aphasia scores. Next slide. So there have been attempts to modify the NIH stroke scale, but in my opinion, the original version remains the standard. This can be done relatively quickly in an acute setting. I was able to do this in 5 minutes, but it may be 10, but you can do this very, very quickly. As I've mentioned, is used as an entry criterion for trials and a selection criterion for interventions. Physicians now in stroke will use the NIH stroke scale score similarly to the Glasgow Coma score in patients with cranial cerebral trauma. So if you're going to do a stroke study, plan on using the NIH stroke scale. Next slide. Now, the Glasgow Coma scale, I've mentioned before, is generally used in patients with head injuries. It basically has the same format, if you look at it, as the NIH stroke scale. There are only 3 items to a test: eye response, verbal response, motor response. Obviously, if a patient is intubated, the verbal response becomes moot, and you'll have to just score the other 2 components. Now, one of the things that I've always had a little problem with is that you get a point for being there because you have no response to eyes, verbal, or motor, but you still get 3 points. Obviously, 3 points is really a problem. This is strongly correlated with outcomes with cranial cerebral trauma, but it's been used in patients with other severe neurologic events that are acute. For example, subarachnoid hemorrhage. It could be used in some other study where you have acute severe neurological phenomena, such as an acute demyelinating disease, or it might be useful for posterior reversible encephalopathy syndrome. Next slide. Now, obviously, there are other numerical scales, such as the Montreal Cognitive Assessment, that is used in a wide variety of studies that are being done in dementia or cognitive impairments. This is a study that can be done by direct observation. I'm sure all of you have been involved with the scale. It has been extensively used and is now kind of the standard test for cognitive testing. It is more sensitive than the mini mental status exam, but it may be less specific. When I had my injury and the insurance company sent somebody to evaluate me to check my cognitive assessment, and having done the Montreal Cognitive Assessment on multiple patients, I was answering the questions for her before she got to the question herself. Next slide. Now, another scale that may be used in a variety of conditions was developed for stroke, but can be used for other relatively static conditions, is the Barthel Index. This is another numerical scale that ranges scores for activities of daily living, such as being able to brush their teeth, go to the bathroom, go up and down stairs, go outside for a walk. The scores range from 0 for unable to do it, up to 5 to 15, depending on the individual item. The scores range from 0 to 100, and each item is added up, and you end up with a patient that's dependent, independent, or totally independent. Those patients generally who have static conditions who require institutionalized care will be a score of under 60. Now, this is very heavily weighted to motor function. There's very little assessment of cognition in here. Still, the Barthel Index is something that is recognized by a wide variety of healthcare providers, especially those who are in rehabilitation. Next slide. Now, another example of a numerical scale, this happens to be a historical scale, is the Migraine-Specific Quality of Life Questionnaire. This looks at the frequency and severity of migraine headaches. This is completed by the patient, and as you can see, it has several items for the 14, saying one is none of the time do they have the problem, all the way up to all the time. And it looks at a variety of the quality of the headache, ancillary symptoms, etc. And this is being used in trials to test interventions to prevent migraine more than in acute migraine therapy. Next slide. Another example of a numerical scale is the Unified Parkinson's Disease Rating Scale. This has been around for quite a time. There are 4 major categories with multiple questions under each. This involves both history and findings on exam. Now, this makes it a little more complicated in mine, because you're going to look at motor examination, motor complications, etc. The other thing is that while each item has a only problems such as no problems all the way to severe problems, 5 items, when you add it up with all these components, you get a range of scores for 0, which means there are really no issues with the Parkinson's disease, all the way up to 199. This gets to be a wide range of scores. And one of the things that will become up a question for researchers will be if a patient has a score of 102 with treatment, and those patients without treatment have a score of 110 or 115, that might be statistically significant, but it may not be clear whether those are really clinically important outcome measures. Patients, my colleagues who are involved with movement disorders probably can give a better response to this than I can. Next slide. Now, on the other hand, after we have numerical scales, we have global measures of outcome. These are widely accepted in the medical community, funding authorities, and governmental bodies. Basically, what we're doing here is differentiating good outcomes from bad outcomes. It could be death, obviously an outcome, severe disability, etc. These are used in a variety of clinical trials in all aspects of neurology. This can be in acute trials, it can be in recovery trials. And so you're looking to see if multiple neurologic impairments affect the patient's outcome. Now, the problem with a global measure is you may miss a clinically important discrete outcome. For example, you may miss the ability of the patient with a stroke to use their right hand for writing, while overall the patient is doing well. For somebody who wants to be doing stuff with his right hand, this may still be not a very good outcome. Some of these have ceiling and floor effects, and generally a global outcome measure is going to require a clinical trial that is larger in size. We'll go from a small, maybe study of 100 patients to all of a sudden 250 or 400 based on the type of scale that's going to be used. Next slide. Now, these are the most common assessments in, with a single score. An example of stroke is the modified Rankin scale. We'll go over this. So we want, as I mentioned, you want to separate the good from the bad. Generally with these scores, the higher the score, the poorer the situation. Next slide. So here's the modified Rankin scale. And you can see the shift analysis that was used to determine responses in a clinical trial. The Rankin scale has been internationally accepted and is used widely in stroke studies. As I mentioned, it has an emphasis on motor function. The Rankin scale can be done by a wide variety of providers, investigators, physicians, nurse practitioners, etc. And people, patients, physicians, governmental bodies, etc., recognize what a modified Rankin score is. A Rankin score of 4, for example, tells you you have a patient that has not a very happy outcome. A score of 1 is what we all want, and which occasionally does happen. Next slide. Now, the Rankin scale has been tested in a variety of assessments. You can see the scale still has some problems. What we found out was that just being an English language institution is not really affect outcomes. There have been a variety of studies that have used it, and new strategies include central adjudication to improve reliability of the scale. While this shows some negative features of the Rankin scale, it still remains a very valid and important rating instrument. Next slide. Now, another uniform outcome scale is the Kurtzke Expanded Disability Status Score, which is used in multiple sclerosis. There are 20 levels of neurologic impairment, with 0 being patient is no symptoms and 10 the patient is dead. But then to make it more complicated, it has half-point increments. So you can have a patient that has a slight change and go from 0 to 0.5, which can describe progressive disability. So what I showed here is you can see how you can have a very minor change to go to a different scale. This has been validated for clinical studies. I will hope my colleagues in MS will look at the Kurtzke scale and see if there are additional ways that could improve the use of this scale. I'm not an expert in MS, far from it, but to me, coming up with a scale that has fewer levels of to rate to me would be very helpful. For example, going from 20 levels to 10 might improve the utility of this scale. Next slide. There are modality-specific scales. For example, this is widely used in rehabilitation. Having looked at scales in stroke, if you go to the rehab literature, you will find a huge number of rating instruments that have been used by researchers looking at recovery after stroke. For example, hand function or posture or changes in status. Still, these are not well understood by the public or the clinicians. And having talked to my people who work with me in my rehabilitation, they tell us that some of these scales are really hard to interpret. And most of them have not gone through the testing that is required on the more global scales that we've been talking about. Next slide. An example of this is the Fugl-Myer score. This has been accepted as a way to assess motor recovery. You'll notice that it has a wide range of scores to a total of 226. It provides a number of items. 0, it cannot do. 1 partially does. 2 fully performs. You can see it emphasizes motor, but sensory balance, joint movement, joint pain all count. It takes about 45 minutes to administer this by a trained physical therapist. Our coordinators tried this, and I think I mentioned it earlier. By the time they and the subject were done by the 45 minutes, neither one were very happy about it. It has not been widely used in clinical stroke studies because of its complexity and difficulty. And I suspect most of the listeners of this in this audience do not have a good understanding of the meanings of the scores on the Fugl-Myer score. I do not. Next slide. Now, in addition, we have quality of life measures. These are going to be required in basically every clinical study going forward. We want to look at physical quality of life, psychological, social, and general health. These are filled out by the patient directly and are influenced by the person's experiences, beliefs, expectations, and perceptions. Generally, these scales have not been the primary way to measure success of treatment, but are an important adjunctive one. There are two scales in stroke. Well, there's a scale in stroke called the Stroke Impact Scale, and then there's the Euroqual, which is being used in stroke and other clinical research studies. Let's go on to the next slide. The Euroqual, which is one that I've had the most experience with, is a brief self-administered instrument. So the patient or the patient's caregiver does this to look in 5 domains: mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. In addition, you have a scale that looks like the score on a thermometer from 0 freezing to 100 boiling, and you ask the patient to put their finger as to where they think they are. Both these components can be used in a variety of clinical research projects, and I would encourage you to look carefully at the Euroqual. Next slide. Now, we're getting close to the done, and hopefully we'll have some time for questions. So when you select an existing scale, please to look about the usefulness of the scale, whether or not the people who have used it have developed educational and certification programs that you can implement in your research study. Remember, you want a scale that your colleagues will understand. Because this is going to be important to compare your prospective research with other clinical trials. And then, of course, it's going to be important to meet regulatory body acceptance. Next slide. Now, these are for stroke. These are the recommendations from the NIH. Neurological impairment, the NIH stroke scale. Functional status, the modified Rankin scale or the Barthel index. Emotional and cognitive status, you can see we have a depression scale. We have the Montreal cognitive assessment. We have trail making, A and B tests. We have participation and quality of life, the Euroqual. We have performance such as walking speed. They do that for me in my when I'm walking in physical therapy to see how far I can walk in 6 minutes. It's a challenge for somebody with a spinal cord injury. You can think about your patients and how far they can go in 6 minutes. It's a good test, can easily be done. Next slide. If you want a trial to go into Europe, look and see what we have. We have functional outcomes, the Barthel index. We have global outcomes, the modified Rankin scale or the Glasgow outcome scale. I've not talked about the Glasgow outcome scale, but it basically has the same set of criteria as the modified Rankin. What has happened is over the years of stroke research, the modified Rankin has been used more than the Glasgow. We did that in our trial of low molecular weight heparinoid. We used the Glasgow. I wish we had used the Rankin. The neurologic impairment scale, we have the NIH stroke scale. I've now talked about the Scandinavian or Canadian neurological scales. Those are also useful rating instruments, as is the unified stroke scale. Being that these are research projects that are going to be in the United States, I would recommend you use the NIH stroke scale as the NIH has recommended. Now, the NIH has similar rating recommendations for other clinical research projects in other areas of neurology. So go to the website and see what can be used, or what the NIH recommends you use. Next slide. So there are a wide variety of clinical scales used in neurologic research. most of the examples I've given today are related to stroke, but just remember that there are a lot of measures available for patients with other neurologic diseases. The choice of scales will be influenced by the validity of the scale, whether it can be reproduced, and the internal construction of it. You want a scale that is valid. You want a scale that two raters can come up with a similar score, or a rater who's doing it can do it more than once with a similar score. You want an internal scale that makes sense. Next slide. You want to use these scales to select patients to enroll in the trial. You want it to be reliable. You want it to be precise. You want it to be valid. You want it to be feasible. And you want it to be acceptable to the medical community. Next slide. Now, the choice of scales will be influenced by the primary aim of your research project. This can be an acute or long-term intervention. It will depend on the duration of follow-up, the nature of the intervention, whether it's a pharmacologic intervention, surgery, or whatever it is. It will be based on your primary hypothesis that your intervention is slowing progression of the disease, hopefully improving outcomes, hopefully not increasing mortality, looking at adverse events that may be related to the intervention or may be not related. For example, a patient be involved in a car crash. And then, of course, you have to record new events. A stroke prevention study is going to have as its primary hypothesis, preventing new or recurrent strokes. That's not going to be the same thing in an acute intervention study. The same thing is true with demyelinating disease. The same way the progression of the disease would be a classic thing for Parkinson's, for example. Next slide. We want a trial to have accuracy of the clinical assessments. This is going to be important for patient selection, for the endpoints, and all outcomes. This involves a plan to educate and certify investigators. Now, this may be less of an issue if it's going to be at a small center. But if you've got a multi-center study, which most studies in clinical research trials in stroke are going to be, you need to know that a patient who's assessed in Ann Arbor will have a score or a measure that's similar to a patient that is assessed in Iowa City. Now, if it becomes important, you can do central assessments. You can do an investigator and go out and see the patient. Depending on the study, you may be able to do telephone or videos, and now teleconference or telemedicine would be a way that you can do measurement of outcomes. And then what happens if you're still unsure, particularly in endpoints and outcomes, you'll have a central adjudication process to look at this. Next slide. So remember, we want to provide a quantitative element to a complex clinical situation. A score will help foster communication, and clinical research studies are described using these instruments. So we want both researchers and clinicians to have an understanding of the information conveyed by the instrument. I think, as I said earlier, most people recognize if somebody's coming in with a Glasgow Coma scale that's very low, that you've got a critically ill patient. Next slide. So I'm happy to entertain questions. It's been fun talking to you. Courtney, how are we going to go through any questions or comments or rebuttals?
Thank you so much for your presentation. I don't see any questions in the Q&A or the chat. You can place your questions in there. You can also raise your hand and I can allow you to talk if you have any questions.
Okay.
No questions, just a thank you.
All right, Courtney, we'll let you take over and do your thing. It's been fun, everybody. Good luck on your
Wonderful.
research projects.
Well, thank you so much.
The CTMC course is really very helpful in developing research projects. I encourage you to participate fully in the program.
These slides will be available. With your permission, Dr. Adams, I can post them on our website along with the recording.
That's fine.
Wonderful. All right. Well, thank you all so much. Everybody have a great weekend. Or actually, there's one question before we all go. Is there a virtual reality-based stroke outcome scale?
No, I don't think there is. That's a good, it would be, well, in some ways there are. For example, you can do the NIH stroke scale through telemedicine very easily. I've done it. You can do an outcome measure in a virtual environment where a central panel or adjudication see the patient. We've done both videos that we've done locally and sent to a central adjudication. We've also done where we're with the patient on site and there's an adjudication panel or expert somewhere else in the world looking at it. One trial, we were sending videos to Scotland for interpretation. I don't know if that completely answers the question.
Next, do you have any tips for scale language translation issues?
Well, you mean in different languages, I'm assuming. Is that, we had to translate parts of the NIH stroke scale into other languages, and it would be important on what it is. And there are societal differences as far as participation in the community. For example, some of the Western European cultures and societies have a much stronger social system than other parts. Some of the definitions for participation in the community may need to be adjusted based on the society. When we had the NIH stroke scale, for example, there are questions on dysarthria, for the dysarthria question. We had to come up with different words that would work in other languages. And the same way, they had to change some of the images a little bit. Cactuses were recognizable to Americans, but might not be quite so recognizable to somebody in Scandinavia. So there has to be some modifications. I know that, for example, the NIH stroke scale has been translated into Chinese. It's been translated into most of the European languages with some adjustments of the individual components, but it does work.
Are there any other questions?
And I would think the same thing would be true with scales and any other area of neurology. All right, Courtney, thank you.
Well, thank you. You have a great weekend.
You too. Everybody in the group have a good weekend. Bye-bye.
Bye.